So, heart disease is one of the big four horsemen of chronic age-related diseases, but for the most part, all we have in the mainstream healthcare system, generally speaking, is a LDL and HDL cholesterol panel that we look at to try to discern risk. However, there's way more to your heart health. There's more to the story beyond just LDL and HDL.
Yeah, most people are familiar with the good or the bad cholesterol that you normally get on your tests that are done at the physician office, but really that's not giving an accurate assessment of what your true risk for heart attacks, strokes really is.
And cardiovascular health is so important for longevity, for preserving quality of life as we age. So we're going to be doing a deep dive in how to assess risk and what is the story beyond LDL and HDL. Is there more that we can test for? I have my dear colleague, Dr. Sherry Kokendorfer, on this episode as well. And let's take a deep dive in. So Dr. Sherry, can you help us understand what really is LDL versus HDL? What are we really talking about here, and why isn't it that they're giving us a full story?
Yeah, and I think a good way to first look at it is that cholesterol doesn't exist just by itself in our blood. It's really like a little cholesterol bubble. The official medical term for it is a lipoprotein, and that lipoprotein is a combination of cholesterol, protein, and triglycerides. And based on how much cholesterol is in the particle, we call it LDL, HDL, or in some cases IDL, some other terms that we use. But what we're looking at is that the more cholesterol a particle has, the more it gets placed into that category of being bad, or the LDL, or low cholesterol.
Quite honestly, I honestly don't like the terminology of, good or bad cholesterol. I mean, cholesterol, generally speaking, is actually very good, and it's very much needed in all processes in our body. In fact, all cells create cholesterol. It's so important that nature has not left it up to us to try to get cholesterol externally. Our cells actually create cholesterol on their own because it's just so important. And with the exception of red blood cells, every cell in the human body creates cholesterol for its use. So I generally hate this terminology of good versus bad, but cholesterol put in a certain environment or in a certain number can absolutely become bad, but it's not inherently bad.
Think of it in this way, that, based on how much cholesterol or protein is in the lipoprotein, or the little cholesterol bubble, that we call it a low density, it has a lot of cholesterol, just a little bit of protein, or the high density lipoprotein, HDL, that has a lot of protein and just a little cholesterol. The traditional test, would dub it good, HDL, bad, LDL. What we're looking at, cholesterol's job for the LDL is to take cholesterol from the liver and out to different parts of the body to get used. HDL's job is to bring it from other parts of the body back to the liver so we can get rid of it. So that's why they have been dubbed good cholesterol, take it away from the arteries, the HDL. Bad cholesterol, LDL, take it to the arteries.
Well, that, theory was challenged. That is HDL really quote unquote good cholesterol, right? In this study by the name of Regards. And what it did was it took about 24,000 black and white cardiac heart disease free participants, and it challenged this, idea of higher HDL being, the good cholesterol. And the study found that lower HDL only predicted increased CVD risk, CVD meaning cardiovascular disease risk, for white adults, and aligned with other studies that showed higher HDL levels are not always associated with reduced cardiovascular events. And this was true for both black and white adults, suggesting higher than optimal amounts of good, quote unquote, HDL were not benefiting either group. So this long theory, or this long assumption that higher HDL has been, the higher my HDL, the more protection that I'm getting, is actually not really true.
Yeah, because the real question is, is your body making a lot of this HDL because it's not doing a good job of actually pulling it back to the liver. So it's sending out more HDL to try to do that job. But basically, is it functional? And that's the real question. And unfortunately, we don't have very good tests to show, is your HDL functional? Is it doing its job or not? And so this study was very interesting because, as you pointed out, it really challenged that notion of, hey, if I can get my HDL really high, I'm protected and it doesn't matter what my LDL is.
Not according to this study. Okay. So, going back to the idea, okay, fine, LDL versus HDL, it's not really telling us the whole story. That is usually what people are familiar with. This is what is on their cholesterol panel, but is there more? Are we missing the big picture here?
Yeah. And, in the traditional test, it does give us some information, right? It tells me generally how much cholesterol I have in my body. But what we found in newer studies is that what really is important is how many cholesterol particles do I have? So how many of those little cholesterol bubbles are floating around in the blood?
Before we get into that, how about we jump into specifically apolipoprotein B?
Yes, this was a point I was going to make as well. In addition to the combination of cholesterol, protein, triglycerides that makes up the LDL or HDL, you have an extra little protein that sticks on the outside of it and helps move it around the body. There's a particular protein called Apo B that attaches to all of what we'd call atherogenic particles. So that means every cholesterol particle that's able to go and make a plaque in your blood vessels, Apo B attaches to it. So a good way of measuring your risk is how much of that Apo B protein do you have, because it's a surrogate for how much bad cholesterol is floating around that can make a plaque.
Very interesting. So it can be almost thought of as like a tag on the surface of all of these LDLs.
Yes, exactly.
Okay. Would you say that Apo B captures the risk of most of your cholesterol particles, whether it be LDL, IDL, chylomicrons?
Yeah, it's really picking up all of the risk. As I said, it attaches to more than just LDL, but it also attaches to your VLDL, your IDL, your intermediate density lipoproteins, your chylomicrons, everything that is going to have the ability to go out into the blood, out to your arteries, and make a plaque.
Gotcha. So it gives you a much more precise picture of what your risk is. And that's where it really comes down to it, right? Because we can actually use Apo B levels along with LDL levels to kind of see if we were either about to miss a high risk person versus are we pushing interventions on a person that may not actually be such a high risk for cardiovascular disease.
Exactly. And studies have come out where we have these kind of discordant results, right? Mm-hmm. Where you can have a LDL cholesterol level that is really high, but the Apo B level is really low. Studies have shown, go with the Apo B. There is less risk of cardiovascular disease if that Apo B is low.
And that would be the discordance, meaning your LDL and Apo B are not following the same pattern. Your LDL is normal or maybe even low, yet your Apo B is high. That puts you at a high risk. That's somebody that can be missed because on a regular panel, they'll see that, oh, well, LDL is normal. You go home, you're fine, just diet, exercise, whatever have you. Yet they miss the fact that this person was actually a high risk person. And then you hear the stories of, well, I was given a clean bill of health and I run. And next thing you know, ended up having a heart attack. I would like to know what your Apo B levels were at that point.
And those discordant results can really go both ways. And that's why getting Apo B is so important.
Right, because the opposite is that your LDL is high, but you're maybe slightly high, but your Apo B is pretty low or normal. This is somebody, why are we, pushing a statin on necessarily? Yeah. All things equal, there can be more to a person's health as far as risk factors are concerned. However, if it's purely based on just those LDL and Apo B levels, then why would you push a aggressive intervention on somebody who's actually lower risk than you initially thought?
Yeah, exactly. But if you have the opportunity then to get further advanced testing, and that's where we come in to your LDL particle count and the size of that LDL particle. Those things can help us, kind of justify and manage the risk that we're looking at, that we've got more and more information to make a better decision about how treatment should proceed.
Moving on to another marker that is not included in your basic LDL or HDL cholesterol panel, Lp(a) or lipoprotein(a).
Yeah.
Tell us a little bit more about that.
So we have all these things. Remember that cholesterol particle, it can be labeled LDL or HDL. Apo B attaches to the LDL particles and gives us that idea of risk. LDL particle count tells me how many of those little cholesterol bubbles are running around in the blood, because that's important. And what size they are, the smaller they are, the riskier they are, the more likely they can kind of slip in between the cells and get in deep in the artery and make a plaque. But then you have a third or a second tag that attaches to Apo B. Lp(a) is what we call it, LP parentheses A. That one attaches to the Apo B protein, and it's like a honing beacon for the arteries. This little guy will make sure that that LDL particle goes into the artery wall and makes a plaque. And
kind of like a autopilot.
Yeah, autopilot. That it's a honing beacon telling it, here's where I go to get to the artery. But that is genetic. About 70 to 90% of your Lp(a) is what mom and dad gave you. It doesn't really change with how much you exercise or what you eat. It is what it is.
Gotcha. Although there are trials happening, or at least I believe it's an antibody that's being trialed out to see if it can actually lower Lp(a) particles, but it's ongoing, and probably, I believe it's not going to, it probably isn't going to even be done until, I want to say 2029, but don't quote me on that.
Yeah, we're a few years out, but it's exciting to think about something that we couldn't necessarily control, and there's people that can come in and have a completely normal LDL cholesterol. They can have a fairly normal LDL particle count, but they can have a very, very high Lp(a). And that one thing, even though everything else is looking okay, is still going to increase your risk of having a heart attack or a stroke. And keep in mind, right, that it's more than just heart attacks. When you have a cholesterol plaque, it can occur all over the body. We worry about the blood vessels in the heart, but there's blood vessels in the brain, blood vessels in the eye, and those small blood vessels.
Peripheral artery disease even, in your limbs. Yeah.
Exactly. Those small vessels we worry about first, the ones in the eye, the brain, and the heart, because they're going to clog before the bigger vessels happen in, like our legs and arms, other spots.
And again, if you don't have the whole picture, you might not actually know what risk you actually have. Are you, thinking that you're not at high risk, but in reality you may be.
Yeah, and that's the important thing, that each of these things that we've talked about, Apo B, LDLP, or the particle count, how many LDL particles you have, and Lp(a), are all independent risk factors, meaning if only one of them is elevated, you still have increased risk. Right. And we're talking like a 20 to 40% increased risk of having that heart attack or stroke by having just one of these be
And this elevated. Is what helps us, risk adjust people, at least, in our practice, that this is what helps us risk adjust so that we can kind of understand, okay, what is, Jane or Joe's, outlook, especially what their goals are. If their goals are to, age in a much more healthy way and stave off chronic diseases such as the ones that we're talking about as they age, then we want to risk adjust them and understand that, okay, well, if you change your trajectory because, hey, you have increased Apo B, if you have increased Lp(a), if your LDL is borderline, what are we looking at? And kind of be as aggressive as we possibly can be so we can stave off these diseases or possibly even reverse them and have them, or the best chance of living to the age of 80 or 90 without, or at least, without any chronic issues that come with these problems.
Yeah, absolutely. And you're right, of looking at the person, right? Because we find that those, when you tell me that of like, gosh, my dad, my grandpa, my uncle, they all died of heart attacks at the age of 45. Well, you have a higher risk. And I bet if we look, your LP(a) is really high, that there is a genetic component to it.
However, in many traditional practices, you'll not see.
They miss that. Yeah.
However, I have started seeing cardiologists order these tests.
Yes, they've known about it for a while, but I think like most things in the medical system, we have all this great technology, but it's all about will insurance pay for it? And insurance has been very far behind in paying for prevention, but they are slowly catching on, and you'll see it's usually they only do it in people that have actually had the heart attack or the mini heart attack.
And that's what kills me. It's like, okay, you're testing all of these things after the fact, after the person has already had the heart attack. The whole point was that if you could risk stratify them earlier, they wouldn't have had the heart attack because you would have caught them, and whatever interventions that we needed to do, either lower their cholesterol, stabilize the plaques, do we need to get cardiology involved for early stenting, whatever have you. But it just pains me that if you were going to check it anyway, why not check it earlier?
And remember, your first heart attack might be your last, and not in a good way. You might die. 50% of the people die from their first heart attack. So waiting until you have the heart attack to do that test and assess your risk, it's too late.
Yeah. Well, actually, while we're on the topic of assessing, let's move on to calcium CT scores, or coronary artery calcium tests. Tell us a little bit more about that.
Yeah, we have two big buckets that they go in. Most people are familiar with what we call the CAC, the CAC, the coronary artery calcium score. And with that test, it's a nice test. We generally, in the traditional system, again, if you've got really high risk factors, like you have diabetes, that you have really high cholesterol, or you've had a heart attack before, that maybe they'll consider doing this test. It is a nice test that tells me if the cholesterol plaques in your blood vessels have been calcified, because it's a process of time. When the plaques are first laid down, they're what we call a soft plaque. And then over time, the body tries to wall that off and stabilize it, so it calcifies it. The problem is this test only looks for the calcification, and it doesn't look for those early plaques that are soft and won't show up on it.
And soft plaques are at the risk of rupturing, and those are the dangerous ones. Once the plaque has already been calcified, it's not going to rupture. Usually, when we're talking to our patients, I'm sure, you give a similar example, but I tell them, it's analogous to, say, if you were shopping for, a house. You look at neighborhoods. You go to a neighborhood and you see houses boarded off, grass is all crappy, looks like, there were burglaries that had happened already in this neighborhood. It just generally looks like a, bad neighborhood. So it kind of gives you an idea of bad things has happened in this neighborhood. So you decide to look at another neighborhood. You go to another neighborhood and you look at the houses, and they look similar. They still have the boarded down windows and the grass is all crappy. Looks like there were burglaries. However, you're also seeing that there's active burglary going on in that neighborhood too. Far worse neighborhood, right? So what am I saying? This particular neighborhood that I'm talking about with active burglaries going on has soft plaques as well as calcified plaques, meaning burglaries that have already happened before are the calcified plaques. The previous neighborhood, all it had was calcified plaques. There were no soft plaques, meaning no active burglaries going on. It gives you a sense of something bad has happened in this artery. Versus something bad is still going on, because active burglary is way worse than what has already happened. And that soft plaque is what we're referring to as active burglary. And when it ruptures, it just pretty much takes over the entire caliber of the vessel. And then if that vessel belongs to the heart or the brain, then you're looking at a heart attack or stroke. So your calcium CT score is picking up on those already happened events.
Yeah, and while it can be a very helpful test, it's not going to tell me about that early disease, those soft plaques.
Right.
And that's where we get into another test called CTA, or coronary artery angiogram. And what that one is doing is actually looking for those soft plaques in addition to the calcified plaques.
Right. Once you do the CAC the very first time, whatever your score ends up being, you image the same person. You repeat it a year later. Your score goes up. Do I need to worry?
Well, no, you're actually at less risk now because the body is now protecting you and walling that off by calcifying it. So you're at less risk of that piece of plaque kind of breaking off and going into a smaller area of the blood vessel and causing that blockage, the heart attack.
So that's the thing, people get a little worried that, hey, doc, my calcium CT score was, say, 100, which is, not good necessarily. But say it was 100, and then next year, say it's 200 or 300. Is it cause for concern, especially if they were taking a statin? Actually, it's kind of good news from the standpoint that the statin actually helps stabilize what were probably soft plaques that were not picked up by the CAC because it's only looking for calcification. Statins help calcify those soft plaques so they don't rupture, because we've already established that soft plaques rupture and cause heart attacks. Yeah. So if that statin is then calcifying these soft plaques, it's actually stabilizing them, but that's also increasing your calcium score. So you always have to take it into context that your calcium score increasing may not necessarily be a bad thing. You just have to look at the whole picture.
Yeah. And I mean, you and I see this all of the time. We still go to the hospital, we help out there, of someone coming in and saying, oh, I had my CAC and it was 0, but I'm having a heart attack today. And that's because all of the soft plaques that were there that have broken off now to cause that heart attack. And that's where, our preference for our patients is doing that coronary CTA so we can get that better look and see those soft plaques.
Exactly. So calcium score of a 0 is not necessarily,
a good thing.
However, again, it just comes, this is why it's so important to have comprehensive look at a person's health rather than just this siloed way of, looking at just one thing for a person at a time versus how does it fit into their overall picture of health.
Absolutely.
As far as who should be getting a calcium CT score, what are your thoughts about that?
For the calcium CT scores, that we definitely want to make sure that we're hitting the high-risk people. So anyone that would have inflammation of the blood vessels and likely higher risk then of developing these plaques. So people with diabetes, fatty liver disease, chronic inflammation, people that have those high cholesterol numbers, because again, the numbers, they're not in your favor when they're higher. That those would be the people. Someone has had evidence of disease already, maybe a mini stroke or a mini heart attack, they would be great candidates for that.
Right. And because that's where this ends up saving lives. However, if you were a low risk person, life well in the terms of, getting their protein in, keeping it to whole foods, not having processed sugars, are not smokers, don't have genetic risk for cardiovascular disease, then not so sure if a calcium CT score, is such a, it may not be as beneficial as compared to the person that we just described.
Yeah. And, in our practice, that we see people as individuals, right? And we're really looking at that. And when we find that even though everything else is kind of looking okay, there's no diabetes, you're good body weight, there's no inflammation, but you have these high elevated biomarkers off of that advanced panel, that's triggering us that there's risk there, right? That we need to look at those people. Yet in some populations, right, where they have a lot of these other diseases, but the calcium or the HDL, LDL look okay, maybe we should still do this test. So there's a lot of things that go into it, but you're exactly right. Someone who's not having those biomarkers elevated, or a disease risk or a family history, maybe that isn't quite as important to do.
Right. Which is why, when many media outlets, kind of shout, oh, everyone over 40 should have a CAC. Speak to your doctor. I think it would, but you don't want to, you want to be cost conscious. At the same time, you want to be as comprehensive as possible too. Why do unnecessary testing? However, at the same time, if it's useful for you, you shouldn't be denied testing either.
Yeah, absolutely.
Moving on to something really important, and it's been dubbed the number one marker for longevity, cardiac longevity. Heck, we're talking about, number one marker for longevity, period. But it has to do with cardiovascular fitness, and that's VO2 max. Can you first tell us about what exactly is VO2 max? Well,
VO2 max is telling us about how much oxygen you use when your body's under physical stress, and when we put you on the treadmill, we're exercising you. So we're trying to take you to that max oxygen consumption, right? And keep in mind, if you go back and you remember those biology classes when you were in high school or college, the body uses oxygen to make energy. It has other ways of making energy too, but the most efficient way for the body to make energy is to use oxygen. So that's kind of a surrogate for your body. When we measure maximum oxygen consumption, we're measuring that maximum output of energy for your cells.
Which is a great surrogate for your overall cardiac health and your overall health in general, actually. How is VO2 max tested?
Well, VO2 max is tested by measuring how much oxygen you use. So there's got to be a face mask on, right? This stuff that you're getting, that you might see your Apple Watch or your Fitbit.
Yeah, I was going to ask then, wearables.
Estimating what your VO2 max is. It's nice, but they're not physically measuring the oxygen, and you want to be able to physically measure how much oxygen you're taking in and be able to also analyze how you're utilizing carbohydrates, fats. So it gets a little complicated with the metabolic portions that we're measuring, but you got to wear a mask.
Yeah, I actually looked up, and I'll read something to you. There's a study that actually attempted to validate multiple wearable devices in terms of their VO2 max accuracy, and found that they all had percentage errors near or over 10%, making them not accurate enough to be truly purposeful in sports or in health.
Yeah, because when you look at our ranges, if you're talking a 10% difference on someone, it could be from putting them in a very low risk to maybe an average risk, right? Yeah. Depending on where you're at in that. So it's really important to be accurate.
But it does help with personal, tracking personal trends. But it's not going to give you, and you want to be accurate when it comes to VO2.
Yeah, you want to be accurate, but you're exactly right. If you're just wanting to see if, hey, am I trending up? Am I going down? Is it getting worse? Yeah, they can help you tell the general direction, but they can't tell you the actual numbers of where you're at. You've got to do the mask. Right. But then the second part is, we're going to work you. So it's maximum oxygen consumption. So we're going to do something to induce that, i.e. put you on a treadmill and push you to your limits.
You start off you start off with the resting too. You want to see what your resting metabolic rate is, and then start to increase the demand on the person. So the most appropriate way to do that is in a clinical setting like we do, or in an exercise physiology lab. But the most important thing is why bother, right? Why care about VO2 max, and why is it that it's dubbed the number one marker for longevity, and a reliable marker that is for longevity. And I'll read you, like I said, another cohort study. It was done on 122,000 patients, and they underwent treadmill testing with an average age of 53, found the following improvements in overall mortality with improved VO2 max. So why do we care about VO2 max? Well, these people, so those that improved from low to below average VO2 max, saw a 50% reduction in mortality over a decade.
Yeah, there's no pill that I can give you that is better than a 50% reduction in all-cause mortality, right? And that, like, if I cured all of the heart attacks, if I cured all of the cancer, nothing is going to give you a 50% reduction, but improving your cardiorespiratory fitness will.
Yeah, and it's worth repeating. Those that improved from low to below average VO2 max saw a 50% reduction in mortality over a decade.
Yeah.
And going from low to above average corresponded to about a 60 to 70% reduction in mortality.
Yeah, and it's crazy. But think about the mechanics of it, right? Cardiorespiratory fitness, again, measuring how well your heart can utilize that oxygen. And where does the oxygen come from? Yes, your lungs, but your blood, your red blood cells are transporting it through those arteries. So if you've got blockages in your arteries and you don't have good flow of that blood through, the body can't pull the oxygen from it and use it to make energy. So it's a really good metric in particular for cardiovascular health, right? And that's why we call it cardiorespiratory fitness, because it's your lungs, your heart, the blood moving through it. Is it able to pull that oxygen out?
It's capturing a lot of information.
Yeah.
And if nothing else resonates with people, the big thing is stamina. It tells you what your stamina is, and putting it into real life examples for people, it's the difference between you being able to travel, meaning, going to an airport from one terminal to another, carrying your own luggage without getting short of breath or needing to sit down. And this is, post-retirement age. A lot of, how many of us think that, oh, well, when I'm retired, I want to go travel the world, I want to do XYZ. But by the time you get to that age, many Americans are not in even good enough shape to be able to take themselves through an airport, walking on their own, carrying their own luggage, forget putting that luggage over the cabin bin, meaning strength-wise. And that's a whole different topic we can talk about at a different time. But all of this requires stamina. Playing with your grandkids requires stamina. Going to a grocery shop for yourself requires stamina. And it may not mean so much right now, but it will when you're in your 60s, 70s, and 80s. But all of that starts, heck, even when you're in your 30s, start working on it.
Yeah, because that's the thing, that as we age, your VO2 max is going to drop.
Absolutely.
Right? That there's things we can do to slow of how much is dropping. But on average, you take a VO2 max of somebody in their 20s and 30s, and if they're not doing something to maintain it, by the time they're 70, it's going to be 50% of what it was when they're 20s or 30s.
Yeah, and I could reliably tell you that, hey, if these are the activities you want to do when you're in your 70s or 80s, I can reliably tell you you're not going to be able to do that.
Yeah. And that's why we love this test, that it's telling us so many complex things about how well the heart's working, but then inside each one of our cells, where all those little mitochondria, those, energy producing units, of how well are they working. And that mitochondrial health is so important when we talk about all these other diseases like diabetes and fatty liver and inflammation. And this test kind of like wraps it all together, right? Of giving us that overall health.
Well, while we're at it, how can we improve our VO2 max then?
Well, there's a few different things that you can do. Certainly everyone's familiar with like that HIIT training, right?
High intensity
interval
Make me feel like I'm dying at the gym.
Yeah, you feel like you've exercised, right? Because you're going as hard as you can, and then you'll rest for a little bit, as hard as you can, and rest for a little bit. That's really good for improving cardiorespiratory fitness.
No, but do I need to be doing it every day?
You don't have to do that every day. We generally recommend for our patients, if you can get 60 minutes in a week of cardiorespiratory HIIT training, that would be ideal.
And that's usually a shocker, because, mainstream media will tell you that, oh, well, hard workout, 600 calories burned, or like, CrossFit, this, that, whatnot. All that gets pushed is HIIT. When in reality, you actually don't need that much HIIT. If anything, you need more
Zone 2.
Ta-da!
Yeah, because, zone 2, you might not necessarily feel all sweaty and like, oh my gosh, that I've worked out today. But that zone 2 training is going to improve the health of mitochondria. And mitochondria is where all the money is, right? Of where all of this exchange of oxygen, of energy production is happening.
Which is ultimately going to help you improve your VO2 as well. Now, I'm not saying you don't need HIIT for VO2. You do. You just don't need as much as you think you do.
Yeah, because you can also improve your cardiorespiratory, your VO2 max, by doing zone 2. You can also improve it by doing resistance training. So it's not just all this high intensity workout that needs to be done for you to see improvements in it.
Or at least not at the frequency that people think that you need to do HIIT training at. Yeah.
And they're looking at different supplements, different things that may help, because these supplements or medications would be increasing your red blood cell count and therefore your oxygen capacity. So, things like ashwagandha, right? That would potentially increase some of the red blood cells, hence the oxygen and hence your VO2.
But nothing beats good old zone 2 exercise. Yeah. What is zone 2 exercise?
And zone 2 is where you're going to feel just a little bit out of breath, right? So if you and I were on the phone and I was talking to you and you were doing zone 2, I could tell that you were doing something, right? And I'd be like, what are you up to? Like, you seem like you're doing something just a little out of breath, but you could still talk to me. You might be able to get out like 7-8 words and a breath, right? Just a little out of breath. And what we're looking at...
But you can still carry a conversation.
You could still talk to me. It would just be like I was working so hard that I couldn't even talk to you, right? Yeah. And really what we're looking at, the technical terms for zone 2, is where you're still using oxygen to create energy and you're not doing anaerobic metabolism to create energy, meaning you're not using oxygen to make that energy. And
meaning when you get into like zone 4, zone 5, where you're, pushing yourself so much where you can barely breathe. Like, you gotta just focus on your
and that's why people get frustrated, because in zone 2, like, how is this helping me, right? I'm not even,
because it's usually boring. It's usually boring.
Yeah, it's boring. You don't feel like you've worked out.
But consistent and boring is where a difference is made.
Yeah, and like the Olympics are coming up, right? And you would think, oh, those athletes, they're so elite, they're so good at what they do, they must be doing the really high intensity. No, they're doing zone 2.
80% of their training is in zone 2.
Yeah, their zone 2 is a lot different than mine, of how high their heart rates can get and what their body is doing, but it's still zone 2 for them, that they're working at something that's less than their maximum ability, right? But that's where their mitochondria are primed and functioning and doing.
Yeah, and mainly because you're teaching your body to stay in the fat oxidation energy system. You want to utilize fat for energy as much as possible for as long as possible. Yeah. That's what makes your body more efficient. That's a great surrogate to know how functional your mitochondria is and how to improve its functionality. Yeah. And this is where I'm going to use a term, lactate. In fact, actually, let's go back to it too, that why is zone 2 even called zone 2?
Yeah, and that zone 2 for us, remember, when you're in zone 2, you are utilizing oxygen. That means that your mitochondria, everything's really efficient. When you're making energy, you can make 36 ATP. ATP are the unit of energy that we describe, currency in our body. When you switch over to lactate being produced in anaerobic, you make 2 ATP. And we're looking for that interface of where you go from making 36 ATP to 2.
Yeah, but the idea is, for the longest time, we've looked at lactate as like a waste byproduct of this process, when in reality, lactate can actually be pulled back in and utilized for energy as well. Zone 2 exercise tells you that right at the edge of lactate being at a level of 2, or below, just slightly below, that is where you're still reutilizing, recycling lactate for energy, versus when it gets higher than a level of 2 in your bloodstream, then it starts to spill out, and that's when you start to get into different energy systems, and you're kind of not making best use of zone 2 training or fat oxidation, that is.
That zone 2, keeping your lactate below 2.
Right. So ideally speaking, gold standard wise, if you are doing your exercise, your aerobic exercise for your zone 2, you'd ideally want to prick your finger and kind of, check to see where your lactate level is. But for the most part, people don't like pricking their fingers. And honestly speaking, you really don't need it.
Yeah, that presumed exertion that we had talked about of feeling a little bit out of breath but talking, it's good enough.
Yeah. So knowing where your zone 2 is, that the perceived exertion while you're doing that aerobic activity can be a very good surrogate of if you're in your zone 2 or not.
Yeah, and we have the ability to, like with the VO2 max testing that we do, of part of that metabolic analysis is I can tell you this is your heart rate with a max fat burn, right? Of where you're in your zone 2, so then you can have an idea too of oh, this is my zone 2 heart rate. Now we will have to periodically check that, because as you become more metabolically efficient and healthier, that heart rate will change, right? Like
that's a good thing.
Yeah, the Olympic athlete versus Dr. Sherry, right? Of where our heart rates are on zone 2.
And the idea is to get more work more output of work out of your body for the least amount of effort. It's kind of like, comparing cars. When you're buying cars, you want a car that has a big engine, but you also want it to be a very efficient gas user. So that is where VO2 comes in. VO2 max is your engine, and zone 2 is your efficiency, how far the car can take you on the lowest gasoline level. All right. Okay. Awesome. So obviously VO2 is very important, and rightly dubbed the #1 longevity marker. We talked about a lot today. We talked about, is there more to story when it comes to your cholesterol, when it comes to specifically LDL and HDL? And there is. We talked about apolipoprotein B particles. We talked about lipoprotein little a particles. We talked about calcium CT score, of how it's beneficial, what the limitations are, and what to specifically look for, and where coronary angiography might come in handy. We talked about VO2 max and why it's important. And we talked about how to improve your VO2 max, including zone 2 exercise.
And I think the real big takeaway is that LDL isn't always bad. It's doing good things for your body, that we need it, and that HDL isn't always good. Having a high HDL might not be the complete story, and that's where these other markers come in, and they're giving us independent risk factors that we can use to risk stratify you and help see of what interventions can give you the biggest bang for the buck, right? Of protecting you against heart disease, stroke, eye disease, peripheral vascular disease, all these things come into play.
So yeah, we definitely urge our listeners to ask for these tests when you go to your doctors, and get involved and really take control of your health. And if you're in the Northern Virginia or DC area and are looking for doctors that do really emphasize these markers and look at preventative health, look us up. Our website is mosaictheorymd.com, and we'd love to hear from you.